thank you very much for the kind invitation. And of course, I'd like to thank Gulnara. I know you're here. Thank you for this invitation, and I'm very happy to be here in your country. So I will gear a little different on what was in your program because hepatitis C is not really a problem in my country, but it's hepatitis B. But I'll give you some things that we are doing. So this is our national program on elimination for viral hepatitis. Okay. Last year, we published a work. So these are the issues that we are going to be giving out. We would like to understand the WHO eradication goals, review the epidemiology and burden, and present a strategic framework for hepatitis elimination. And at the end, come up with operational gaps and challenges in its implementation. Last year, we published a work on the Lancet on the different countries collaborating together on the so-called viral hepatitis elimination program and try to see what are the differences one country has over the other. So these are the identified 20 countries with most heavily burdened with viral hepatitis. Identified before you on red dots are those that are seen in Asia. Now, when you look at it closely, more than 5% of this prevalence, 5% prevalence in hepatitis B occurs in our region. So this is a challenge for us, and as I mentioned, this then produced now the demographics in Asia with the different countries with more than 5% prevalence. So I just highlighted the different countries: China, Indonesia, Myanmar, Vietnam, and at the end, the Philippines, my country. And you can see that hepatitis B vaccination is actually present in all the 5 countries. The hepatitis B receiving treatment is actually not a problem. Access to treatment becomes a problem to them. And of course, hepatitis C receiving treatment seems to be also a problem because of the cost of the drug itself. So even if WHO and all of these countries give us these drugs, it's the access and the most of these countries are out of pocket, and therefore being a very expensive drug has its own disadvantages. So here before you are the gaps that I identified. I think from the last 4 or 5 speakers, you've already gotten to know what the different gaps that actually cross around. Seems to be the same in all countries. So it is actually the insufficient awareness, as the COVID-19 produced a problem in some of the countries. And of course, there are already steps because this is a concern, and therefore steps are being done to address the concern that has been given. And therefore, there are national action plan on all of the 5 countries. So what then is the problem? If all of them identifies the problem, if there is a national action plan that is already in place, maybe it's the implementation of these goals that comes to be the role of the government that becomes an issue of concern. Therefore, these are the identified hepatitis policy index. I'd like to highlight my country because it is from 2018 to 2023. So my country went backwards. If you can see, is this a marker? And you cannot use the marker in laser. So anyway, if you look at my country, it's backwards. Instead of the blue, which is 2018 going forward, which means you actually hit on your policy, my country was going back. And this then became a concern when I saw it. And it actually moved us to see where are we really now in viral hepatitis elimination? Are we going back because of the COVID, or are we doing our share but quite slowly? So these are the identified priorities. I think everything is there, from ensuring diagnostics, access to treatment. You have to monitor progress. Financial is very important, especially in our region. Funding, and of course, the tests and models of care. And before you are the identified factors that are related to hepatitis B infection in Asia. Now, if you look the top one, it is limited availability of the epidemiological data. It seems to be across the board. And of course, the low level of awareness because there are more patients with hepatitis B in our region. Therefore, the healthcare workers burdened with all non-viral, non-communicable diseases then becomes an issue. And this is what a problem now. On top of the viral hepatitis that they have to think of, they have coronary diseases, they have gastroenterology, and colon cancer is also rising in our country, in the region. Therefore, this then adds burden as far as our healthcare workers are concerned. So this is what is happening in my country. The prevalence rate in 2017 is about 16.7%, and hepatitis C is 0.6%, but these are all in blood donors. The case fatality rate is about 0.82 to 1.29%. There is a high prevalence among men having sex with men in hepatitis C, and the prevalence data has gone down in 2017. And when you look at the burden of the disease as far as age group, you can see that we are doing our share as far as vaccination is concerned. Now, this is a surprise to us this year that when we did the modeling burden, we would see an 11% expected decrease by 2030, and for hepatitis C, an 84% reduction in HCV, and at 92 to 93% decrease in liver-related disease, morbidity, and mortality. So what then happens? And this is the new data, from a 19 or for 16.1%, we went down to 4.4% with 3.2 million adults living with chronic hepatitis B. And therefore, we did have a substantial decrease from a 1.7%, a 73.7% decrease from 5 years ago. So which means now that since vaccination program has taken its toll, it seems to be showing already its progress in our country. The highlights is progress in prevention and control efforts. And before you are the possible contributing factors. This is the improved vaccination, the enhanced blood safety measures, the better infection control practices, and the increased awareness and education. On the right side of your screen, this is what I was telling you. It was not really a problem as far as hepatitis C is concerned, but we do have, and this is about 0.2 to 0.3%. And it translates to approximately 220,000 adults with 100 million population base of the Philippines. Therefore, this is actually the first national representative estimate with a consistent with blood donor, which is about 0.3%, as I mentioned initially. And therefore, if you look at it, we are relatively low compared to the global estimate, which is about 0.7%. So I think hepatitis C will eventually be a thing that we can control, but hepatitis B is still something that we need to work on. With our last president who has very tough rules on drugs, because most of our patients with hepatitis C are on drugs, this actually helped us decrease the hepatitis C burden in my country. So what are the actions that were taken? Clearly, there are actually 4 actions that were taken towards viral elimination. We did have a national viral hepatitis task force, and this is actually to centralize the guidance policies and creation of different strategies for elimination. There is now a strategy of incorporating it to a primary care healthcare. Now, the reason is that we are not like the other countries. We are an archipelago. We have 7,100 islands that is actually separated by bodies of water. This alone makes me different or difficult to control healthcare. And we cannot be compared to the US or to maybe to your country because we need to travel. Patients need to travel to see specialists. And therefore, the need to educate your primary care physicians is a strategy that should be implemented in my country. We've expanded the access to screening and diagnosis, and this is using the community-based screening, as I mentioned. Even if your WHO gives us a screening, but they need to travel through through the boat, which is what, $100 or $200 just to see a specialist and just to get screened, seems to be difficult for us to do it in the community. We need to enhance public awareness and, of course, improve immunization program or coverage. Now, this is the first thing that we did. This was before the COVID, and the COVID really helped decline this thing. This is the Halt and Reverse Hepatitis B and C by 2030, our program of implementation and framework. So we are on the third process, which is at 2020 and 2022, which is the execution. And of course, the COVID did not help us at all. It actually shelved the hepatitis B. Our immunization programs were all at a problem. And this was seen in this figure. On top of your right screen, you can see that there are two problems that it went down. One is when there was no good information dissemination to our low-key community members. And the other one in 2020 is because of our COVID. But you can see the laws are in place, implementation is in place, but because of the different government problems that we have, this actually pushed that the coverage of immunization went down to 50%. These are the information dissemination, which is not different from what you all have. And we are doing our share both in private and public. And of course, as I mentioned, the different administrative orders are all there. It is actually the different strategies of advocacy, research, halting transmission, and access to effective treatment and monitoring evaluation. So these are the different operational indicators we have. That seems to be a difficult strategy, as I mentioned, because we are an archipelago, and I'm very happy that in 4 or 5 years, we have decreased 73% of our prevalence rate to what it is now. As I mentioned, financing is a problem, and therefore we need to have, we went down as far as using our maternal and newborn and healthcare strategy, working with our pediatric group. We have hepatitis screening. As you know, the Philippines has a lot of overseas workers, and therefore this is not being paid by our insurance system, and now we were able to lobby it. So this is one of the strategies we used because of the healthcare strategy. This is putting hubs. We call it hubs of hepatitis. We were doing this in 2020. We actually team it up with TB and HIV, but you can see that along the way it suffers because you need people to handle it. I remember we had to close down the hub because the TB, the healthcare workers became infected with TB. So that when people talk about this in forums that you need to put it with TB and HIV, it's so difficult to do it in the community level, in the real world scenario, because patients with hepatitis B will never want to see them coming in on an HIV clinic. So that seems to be a strategy that we need to move on. For hepatitis C, we have a memorandum already, and we were able to address this, as mentioned, a very low prevalence rate. So in other words, the gaps that were identified are before you in viral hepatitis, from the access to drugs to linkage of care, and of course, different strategies of putting it in government hospitals. And these are the different stopgap strategies that we did. We anticipated now, as I mentioned, primary care physicians to be moving on with us. The Hepatology Society of the Philippines is moving together with this. We have already to rethink our strategies for immunization, and now the Philippine College of Physicians is active in promoting not only hepatitis B vaccination, but adult vaccination. We are revisiting the different expansion programs in the DOH. And of course, as I mentioned, the Department of Health is getting into the limelight in the next few months. What happened? So the Philippine strategy is actually the same as the strategies that were identified initially. And this is a different one, not really different because maybe the only difference is we are an archipelago, and therefore we need to have hubs, we need to have people working together. And if you say you use a app, is quite difficult because not everybody can be reached with a very good system of the internet. So these are the real world scenarios that we have to address, and I think we'll be there in the next few months. But I think the challenge here is the challenge to treat all. I've been pushing this for all of the conferences that we do because patients will not go back to me. So patients will need to be given a drug and maybe a treat all patients wherein you can actually decrease the amount of follow-up of your patients and probably the amount of testing, which actually will be now a problem because we need to see how this will actually have an impact. So lastly, I think we need to, you have a close parameters for your traveling and you do 10,000 steps a day. So we need to close the hepatitis circle together. You address medical unmet needs, urgent solutions, research, and call to actions. Whether we are from a hero, zero to a hero. If you ask me, we are on track, slowly but surely. Thank you for your time.